And welcome back for this second part of the conference. We will now have this roundtable on European perspectives on health data sharing, which will be moderated by Marcus Kalliola here. He is the project director at the Finnish Innovation Fund, Sitra, and he will be your host. On this roundtable, you'll also have Joanna Maria Gligor, head of unit digital health of the European reference networks at DG Santé from the European Commission. We also have Peja Haramo here. She's a chief metadata specialist at Findata, the Finnish Social and Health Data Permit Authority, which you've heard of in the first roundtable. We have Emmanuel Bacri, our Chief Scientific Officer at the Health Data Hub. And we have Irini Kesisoglu from a researcher at the EU Health Information System Unit at Cienzano from Belgium. And lastly, we have Bernard Hamelin, a member of our Scientific Advisory Board and former head of global evidence at Sanofi. Unfortunately, Ségolène Aimé, our vice president of the Scientific Advisory Board, could not be here today, but she sends her regards. And I will just, hand the floor to you, Marcus.
Thank you, Sam. Thank you, and thanks for the French Health Data Hub for inviting and the French presidency for having this event. Before we start, I would like to congratulate Luisa Stuve on her birthday. So it's your birthday today, so happy birthday, Luisa, from the Ministry of Health. Has been great working with you for the last couple of years. All right, so let's go to the roundtable then. So it comes at a very specific time. Last week, the European Health Data Space Regulation came and it was published, and there has been a lot of discussion about that. So this will continue the discussion that has been started and will be, of course, ongoing for the next few years. So we have a lot to talk about regarding that. And the session is titled European Perspective of Health Data Sharing, to distinguish from the first panel, which was mostly about the national setting. So you heard about the Findata, you heard about the Health Data Hub. So now this panel will concentrate more on how the countries can do cross-border sharing of health data and how that works. So the discussion will be mostly divided into two parts. So we'll first discuss the ASI situation, what kind of sharing of health data there has been so far, what has been the barriers and the problems, and then we will go more into the future and what will happen. And also, of course, you will have the possibility to ask questions. So whenever you have something on your mind, then please put that in mind. And after the panel, you will have the chance to ask here or then online. I will have the questions on the pad here. So I will ask the questions. So please put in mind if you hear something specific you want to ask further details. So let's begin then. And let's start with the more positive note on the situation, because we know the health data sharing is never an easy topic. But we have a lot of experience here and probably also some good examples of how health data has been shared in the past and how it has been used in the research project or decision making. So I would like to hear from all of you some examples from your past or that you know where the health data has been shared in a secondary use purposes. So we'll start with Joanna there at the end. Joanna, welcome to the panel, and what positive examples you would have to share us.
Thanks a lot. Thank you very much for the invitation. Indeed, at European level, there were a lot of initiatives related to the use of data for secondary use of health data for research policy making, regulatory purposes, especially, for instance, supported by Horizon 2020, Horizon Europe, research infrastructures, also support for the registries, cancer registries, rare disease registries, etc. Also, EMA has set up a project on having access to the data for regulatory purposes in order to overcome the limitations that they were facing during the pandemic as well in this area. However, I think one of the characteristics of these projects was that they were quite disease-oriented. The cooperation between different diseases was relatively limited, and also the cooperation between different countries was relatively limited. Sometimes there were also legal organizational obstacles for accessing the data, for using the data for secondary purposes, etc. So this is what we are trying also to remedy through the European Health Data Space legal proposal, and also through the pilot project on an infrastructure for secondary use of health data, which is supposed to support the cross-country access and use of health data. So, for instance, a researcher applies in France and wants to have access to data.
Joanna, we will go into that.
Okay.
Soon. So we still know in the first and in a more positive way of how the health data has been shared. So you said that there has been a lot of research project. The EMA is having the Darwin project and others. So there are some examples that the health data has been shared in the secondary use.
Yes, yes, right. Indeed.
So we will give the floor back to you in a few minutes time to come back to the issue. And we go now to Peja for the first speak from your side. What is the positives that you could share from your past?
Okay, thank you. Well, my background is strongly in epidemiological research, and I can share some experiences from 2 recent studies I took part in. There was a study called KEPOS Link on psychiatric hospitalizations funded by EU in Framework 7 program. And we studied 6 European countries where partners in this, in Finland, Norway, Austria, Italy, Slovenia, and Romania. And you can imagine they had very kind of different types of health service interventions, very different healthcare systems, different healthcare funding systems. And we examined the psychiatric re-hospitalization there, and also examined data availability, acquisition of data, data management, data quality, and interoperability there, linkage methods. And it was very interesting. And it was great to be able to conduct this study. And that was in 2014 to 17. And after that, I took part in a recap study, Horizon 2020 funded study from 2017 to 21. And it has overall 20 partners from 12 European countries. And it was mainly clinical cohorts from these countries, but we had work package on 4 Nordic countries, Finland, Sweden, Norway, and Denmark, focusing especially on the secondary use of register data. And we were able to, using these Nordic registers, we were able to study preterm birth and its effects into infancy to adulthood, utilizing these very long registers in the Nordic countries. So I think that these 2 studies are good examples how the secondary data has been possible to use already now before the EHDS.
Thanks. Emmanuel, on your side.
Yeah, so at the Health Data Hub, so we're pretty young. We're about a little over 2 years old. So strictly speaking, we haven't been part yet in success stories that would operate at a European level. We are part of stories, but we'll see if there are success stories. Hopefully there will be success stories. And one of the stories is a story with Finland, which is a research on cardiometabolic diseases. So that's a collaboration with some French and Finnish researchers. Now, what I would like to say is that I think nobody here doubts that if we organize something like the European Health Data Space, there will be many, many stories, success stories. I mean, this is pretty obvious. And just thinking about the pandemic, it's clear, I think, to everybody that if we had such a thing as a European Data Space during the beginning of the pandemic, following the surveillance of the pandemic would have been much easier at a European level. And so that could have been success stories, and hopefully there will be many, many more.
Thanks, Emmanuel. Arini.
Hello, does it work? Yeah.
Yes.
Okay, so, well, in my opinion, more large scale, as Jan also mentioned, one big success story is all the European research infrastructures. For example, Elixir, or because I have a background in neuroscience, the Human Brain Project. So these have shown that, yes, there is an exchange of health data in the European level. And then in a more smaller scale, in universities have been collaborating between different countries, member states, to share health data and do projects that would develop new diagnostic tools and treatments. The only problem that has been faced at the moment, and where the European health data space would easily facilitate, is the time to access the data.
All right, Bernard, on your side.
Well,
Is your mic on? That would help.
For me, the best example of although limited, the sharing of information across Europe was the COVID-19 pandemic period, because the data that were collected by country that helped every country to guide their policies, shared across countries, was extremely useful, for instance, for the industry to start to look at the design and development of new vaccines, or the design and development of new molecules treating patients. And that information, of course, maybe not as well coordinated as the CDC does with the 50 states in the US, where they were able to build model on a weekly basis to predict what was happening, did produce a lot of information in Europe to guide most of the vaccine producers and to generate the data we have been able to generate.
Thanks. Good examples from all of you. I'm sort of happy that we received these good examples, because for the last 2 decades, we've been putting money into research. And if we didn't have any success stories, then that would have been useless use of money. So of course, it's good to hear that we have been able to accomplish something. But during these years that we've been doing cross-border research in EU, we probably have faced also barriers and problems, and things are not as seamless as it could be. Also, a lot of the things cannot be solved by doing the same thing all over again and expect better results. So that's why we have something as a new proposal. But I would like to ask from you again, from your experience, and what have you learned from your past, some barriers for health data use. What have you encountered during your careers? And we start with the revised order, and then we stop before Joanna. I will not give you the floor. I want to ask you something specific. So we'll start with Bernard first.
Okay. Let's start with the clinical documentation of molecules. You measure most of the benefit and risk of new treatments using clinical trials, randomized clinical trials. But the randomized clinical trials, although they are extremely powerful to limit bias, it's a picture at one time. They have many limitations. The diversity is maybe not as wide as you see, and there are a lot of factors you don't capture in the clinical trials that influence significantly in real life benefit and risk. So the additional value of real world data complement in a very nice way what the clinical trials are producing. Now, for benefit risk assessment, EMA is organized to standardize and to produce guidance, and they are working very closely now with the industry to guide the companies to how to use them for benefit and risk assessment. The problem is in the second wave, when you have a drug approved and you want to access a market and you want to use the real world data to complement the unknown, the uncertainties that still remains after the assessment of the benefit risk, and that you have very different approach by different countries of how you assess these data. The lack of standardization of HTA and policies in different countries hinder the ability for us to be able to be very effective using, as we do for benefit risk assessment, large trials across Europe. We need to do it by country. And that, I think, is a limitation, doesn't add a lot of value to the product. It is maybe more adapted to the practice at the local level, but I think there is probably benefit to look at the better standardization of how you assess these secondary use of health-related data.
Thanks. Irene, please.
Yes, actually within DREES, we have been conducting a study to look at the barriers for sharing health data for secondary use. And some of these barriers have been in the legal aspects, some were because of data, and some because of transparency. So I would like to just mention a few. First of all, a barrier that has been mentioned by many stakeholders is the different interpretation of the GDPR. So a lot of legal officers in different institutions in different member states need clear guidelines on how to interpret the GDPR and legislation. Also, I'm sure for the European health data space is going to be the same. So they would ask for a platform where DPOs and legal officers can come together and share best practices on how to interpret legislation. Then another more technical barrier is the fact that at the moment there is no common metadata catalog where you can find all the available data collections in Europe. So that's the findability and discoverability issue. And then another very important barrier is interoperability. In order to share data between institutions and also between countries, you need to have structured data and also interoperable. So using harmonized way of collecting data, storing data, and also standardizing, using common data models.
All right, thank you. Emmanuel, please.
Well, it's going to be hard to be original after what has been said. I mean, of course, we all agree. I mean, we all have the same barriers. I mean, so we discuss with Irini and with Bernard all the time, and we all agree on that. So if I had to sum up, I think most of the barriers are from interoperability. And actually, the legal problems, you can see it as an aspect of the interoperability. Interoperability has several aspects. You have the legal interoperability, the fact that you have extremely heterogeneous governance systems, even at a national level. Interoperability is a major problem at a national level, and of course, an even much bigger problem at the European level. But we also have a problem of interoperability, legal interoperability in the countries. And of course, it's a nightmare if you want to address this problem at the European level. And then you have the syntactic interoperability, the fact that you would like to have all the data sets to be on the same format. And then you have the semantic interoperability, meaning that the coding that is made in these data sets should be the same, so that when we're talking about a disease, everybody is talking about the same disease. This is, of course, extremely important. And we had this problem at the beginning of the pandemic because COVID, there was no test. So everybody was talking about COVID, but they were talking about different things at the beginning. So I think if we have to just keep one word in our mind, it is interoperability.
Thanks. Finally, Peja.
Yeah, as Bernard said, it's very hard to be original at this point, being the last one, but I can really just mainly to confirm that all the worries that the previous speakers have said, that we have also noticed in our studies that really the interoperability, harmonization, it's one of the biggest challenges there. And then, of course, data protection, data security issues, different interpretations of GDPR. And as you said, also not just the kind of cross-country differences, but also locally, there can be very different ways something is in the registers or kind of the data in different parts of the country. And the lack of metadata, that's true. It's kind of regarding the availability of the data. If you can't know what's in the registers, it's very difficult to start the actual study and to then go to the harmonization if you don't have good metadata to really understand the data first. And of course, if there's something, and of course, from the Nordic perspective, saying that, well, linking the data is very easy in the Nordic countries, as Johanna said, also in the first roundtable, that we have this personal identity code that we can use to link, like, you name it, we got it, like all the data. But then I'm sure that it's even bigger challenge in many other European countries to really ensure that we are linking the right persons there. And of course, the data availability overall. And of course, if I may add one thing, it's maybe of course, now we are talking mainly about the kind of European data sharing, but of course, then we might have transatlantic partners, etc. and that adds another challenge to these projects. Yeah.
Thanks. So now we heard from the 4 experts, and you agreed in a lot of the barriers. And I would like to give the floor now to Joanna on these barriers. But I would like to mention that if any one of you have been able to read the proposal, so it gives also a lot of studies that you have conducted before the proposal. So you studied these barriers. So anything new came up from here, or anything you would like to add as some of the major barriers that you found from these studies? And of course, then I would like to give the floor to you to answer regarding the new proposal that has been given. Does it give an answer for these solutions? And you can now spend some time explaining how you actually how you are going to solve these barriers with your new proposal.
Well, I think it's indeed extremely difficult to be original on the barriers. I mean, we have noticed broadly the same barriers. Maybe just to add that in terms of legal interoperability, I would say the interpretation of the GDPR was indeed extremely fragmented. In some countries, there was also an overuse of consent, which added additional costs for the researchers and difficulties in getting data. There were some countries, but again, quite, I think, well, France and Finland are clear examples, and they were really used as an inspiration, which used the opportunities offered under GDPR, under Article 9 of a national law for processing data for research policy making, etc. So what we have been doing in terms of overcoming the barriers, these interoperability barriers, and on the legal side, we try to, again, use the opportunities offered by the GDPR and come up with the EU law, which tries to harmonize the conditions for access to data for research policy making, regulatory purposes, innovation, etc. Of course, the consent remains there. It's another legal basis, but what we are trying to do is to provide the safeguards for the processing of the data. And I think, speaking now about organizational interoperability, what we have been noticing in all the legislation on secondary use in different member states was the trust, which is being ensured by an authority, which provides data for specific projects. The processing of the data is done in secure environments. So basically the data user gets access to the data he or she needs for the research itself. So there is a data limitation, data minimization. The data is being either pseudonymized or anonymized, but the data user doesn't have the key to re-identify the data subjects. There are also very strict conditions and basically banning of the re-identification of the data subject. And also in the context of the European Health Data Space proposal, we have listed very explicit purposes and prohibited purposes. And this is something which, for instance, the French and also the Finnish law are of great example. For instance, the prohibited purpose of using the data against the person, of using it, for instance, for increasing or for modifying insurance premia, or producing harmful types of basically devices or products or services. So I think these are basically the elements that we were trying to take into account in terms of organizational interoperability. Now, when it comes to the semantic and the data quality aspect, there we try to address it in 2 steps. First of all, from the perspective of the how the data is being collected in the primary use, and also from the perspective of quality data label, minimum data sets, and an EU data set catalog in the context of the secondary use, so that the researcher knows what data exists where. And we are also trying to support basically at the level of the European Commission, the building up of the EU dataset catalog so that a researcher from Finland knows what data exists in France, what that data exists in Netherlands, in Romania, Bulgaria, etc. And can also, through the new infrastructure where we have launched a pilot project under the EU for Health, we try to support the communication between the health data access bodies and ensure that, for instance, a French researcher who applies to the French data hub can also ask the data from Finland, Netherlands, etc., Denmark, Norway. I think Netherlands is not yet among those who are included in the possible winners of the pilot project. I don't want to speculate. It's Hadea who's doing the evaluation, but. The idea would be that there is the possibility of applying once, and then the organizations would transfer the request and would support the researcher to have access to different data in different member states. And in terms of external cooperation, there are also elements in the legal proposal that could allow for extension of the cooperation, provided some elements, and there is basically no restriction with regards to the health data access bodies. So I hope that I have replied to the main barriers. There are a lot of things to be done, and I would like to thank again to TEDA's joint action, which has already started identifying the barriers and identifying also solution to those barriers, and also. Clearly, these elements have to be taken forward. Maybe one more element in terms of the trust and security. So the secure environment indeed is one element which is common in different countries, and we are also aiming at setting up at European level the security standards for the secure environment, also building upon the work that has been carried out in the countries that have already more experience in this area, and this will be basically done through an implementing act.
Thanks, Joanna. Of course, it's difficult to explain it without slides and without the short time the complex proposal. But maybe a short round of reactions. How do you find the ESDS and the Joanna's answer to your barriers? Do you see that the ESDS proposal can fix the problems that you raised, and not only based on Joanna's answer, of course, but if you have getting familiar with the proposal before today? So we start with the revised order from Peja, and we move closer to me then.
Okay, thank you. Yeah, I think that it's very interesting, and I think that it really attacks many of the key barriers, and I'm really hopeful regarding it. Especially, well, the metadata issues, as you mentioned, and we've in Findata, and I especially have been kind of responsible for the coordination of our national metadata catalog, and I'm really looking forward to kind of bringing it to the kind of European level, and I'm sure that's one of the very key issues there. And of course also in Findata we take data protection and data security kind of very seriously, and that makes me also very happy to if we can get some kind of international EU level standards there and make the cross-country data sharing easier in that way. So I'm really looking forward to that development there.
Yeah.
So yeah, of course, this is a major step. I mean, this is clearly a step that is addressing most of the barriers we have been talking about. So harmonization of the access rules, but of course also, and maybe we haven't mentioned that, it is clear about the fixed access time also. This is which is extremely important, and and also gives the different official rules to the different institutions within the country. So to just really understand what would be the role of different actors in each of the country. And then there is one major issue that the text is addressing also, and that we haven't mentioned yet, which is valorization, financial valorization. So it doesn't solve the problem, the text, but it gives the framework for solving the problem. And that's a major step in itself, because it's a very, very, very complex problem, I think, in all the countries. And at the European level also, it's like how much and what, how should the price be computed for accessing the data? This is a major issue, and there is a framework to discuss that within the text, and I think that's really great.
Thanks. Arini.
Yeah, so I think indeed that the EHDS proposal is a great opportunity. It addresses most of the barriers and takes some options that we have seen in TEDS. But there are a couple of questions that I have to you, Jana, actually. So first of all, something that would be useful would be a reference document where you can see in what common data model or what technical standard, what syntactic or semantic standard, the data is stored in different data collections in Europe. Would that be something that you consider? And the second is about, you have a list in the legislative proposal of the purposes for secondary use of data. Is this list expansive? Like, is it flexible to extend it? And does the private, actually, the use of data from researchers working in the private sector, is it part of this purpose list? So yeah, this is for now. Thank you.
Joanna, you want to react right away for those questions? All right, Bernard, if you want to, does the
No, I think in
solve
the
your
end,
problems?
so I think we are I'm not going to be redundant, but I'd like to focus on for the industry to have a single shop for across Europe. So you don't have to apply in every country. It would be extremely important and avoid a lot of complexity of administrative, and the timelines. Timelines is very sensitive, but because we work under very tight timelines, these two elements would be carefully looked at after the pilots.
Yeah, and I think also the upcoming Pharma Act answers some of your questions regarding the access to the real-world evidence on the clinical research. Joanna, would you like to react on the Irini's questions regarding?
On the common data model, this is something that would come in the context of the data quality label. So these are among the criteria that will be looked at in the context of the data quality label. However, of course, all the elements of the data quality label will be further on detailed in tertiary legislation, and then implemented at the level of the each data source and data set. And there is also the possibility, basically, of a certain level of standardization through the minimum data set, and there are some rules in this with regards to this aspect. On the purposes, this was one of the complex discussions, and I think it will be even more complex in the context of the negotiations. So basically, the proposal does not make a difference between the data sources, public or private. So from this perspective, we have been looking very carefully at the Finnish and also the French legislation. So basically, we have been trying to articulate also very carefully with the Data Act, which supports the access of the public sector to the data from the private entities, especially for emergency situations. And the European health data space builds upon. The health data access bodies could support the public entities to provide access to data, but goes beyond, because there is the need both for the public and the private sector to have access to data which can be private outside very specific emergency situations. So we are trying to provide this framework with the other safeguards than the ones which are in the Data Act. And we will see how the negotiations will go there. There is the possibility both for the public and the private entities to access the data. And there are some elements under the article on the purposes 34 related to, let's say, private use of data, for instance, in the sense of research and development, innovation, development of products, but there is still a focus on contribution to the public general interest, I would say, to the public health, to the safety and security of the medical devices and medicinal products, etc. And I think there is a lot of work which has been carried out by the existing health data access bodies that will clearly need to be further developed in order to further refine probably these purposes. And as I said, I mean, probably this will be one of the hot topics in the negotiations between the co-legislators. Maybe one element that I would like to add in terms of the legal basis. So the European health data space provides a legal basis for the health data access bodies, also an obligation for the data holders to provide access to the health data access bodies. However, basically the data users needs to show their GDPR legal basis in the context of Article 6 and 9 of the GDPR, be it public or legitimate interest. So this is very important, and probably that would also, it's an important element that has been taken into account, for instance, with the revision of the EMA regulation and ECDC regulation to ensure that they can have the capacity to access real world evidence. So, yeah.
Thanks so much for the answers. So I think we can now all agree that the regulation is solving at least some of the problems, most of the problems that we have raised. But the regulation is, of course, one thing, and we could put in the regulation that we need to start a colony in Mars. But if you don't have the rocket, then if you don't have the capacity, so we never get there. So Irene, you have made some country visit by CNSANO in the Tehdas Action, asking the countries of what is the capacity to act in the secondary use of health data. So what have you found, and do you think we have the capacity to actually implement the regulation in EU?
Yeah, so just a brief mentioning on what we did in the country visits. So we have been, as part of Tehdas, since I know we have been doing, we're planning to do 12 country visits. At the moment, we have already done 6 country visits. And what we do is that we map the health data management system of these member states by interviewing around 15 to 16 stakeholders of the health information system, of hospitals, industry, universities, researchers, and asking them questions about the different data collections that are available in the country, how do they store data, access data, about interoperability and the infrastructure that is there. And of course, to answer your question, we have been asking questions about their preparedness to join the European health data space, what resources they have and what do they need, and in terms of training, what they need in terms of capacity building. So generally some comments that we have, first of all, is that the first basic is that there needs to be an enabler for digitalization, because it's not very surprising, but some member states still have paper-based data. So first step is that all health data should be, or most health data should be digitalized in a structured format. And that also, as it was also mentioned by Johanna, the unique identifier is key in order to use data for secondary use and to link data. So that's just one general point that is very basic. And then another general and important is that in all the countries we've seen until now, actually, they all have political will to join the European health data space. So no one is against it. Everyone sees the benefits. Everyone has started already working towards building health data access bodies, towards building a national contact point, towards developing legislation for secondary use in the member states. So countries are getting prepared to join the European health data space. Regarding resources, there is a lot of need of financial and human resources. There's need for data stewards, which is a new job opportunity, actually. It didn't exist before, I think. Then there's, of course, legal officers that are needed, statisticians, cybersecurity experts, data analysts, and there has been an idea actually from Belgium when we did the country visit to create the Health Data Academy. So maybe some kind of university where you would be training people in all of these different jobs. So then, yeah, the training needs, let's talk about capacity building, could be on how to access data. So to make the process of accessing more transparent, and to help and support researchers in this process, because researchers might not know all of these more administrative processes. And I guess, and another very important aspect about capacity building is data literacy. So data literacy in the healthcare provider sector, to explain to healthcare providers how important it is to store data in a proper structured way and the benefits that you get from that. And we saw that in Denmark is actually a very good example where they are doing it. They have an IT infrastructure in every hospital that is helping healthcare providers to store data in a proper way, and then they receive positive feedback if they have done it properly, and they can see the benefits. So this is a good best practice that could be taken out in different European countries.
Thanks. Would anybody like to react on this capacity question? Do you think that member states are ready? Joanna?
Thank you very much. So on the digitalization, I would like to underline that there are important funds at the level of the member states which can support the digitalization. There is the Recovery and Resilience Facility, where the member states have earmarked around 12 billion euros for the current multi-annual financial framework for digitalization at the level of the hospital. And that's a very positive news, because that will clearly impact positively on the data availability. On the Health Data Academy, we are trying to set up the European Health Data Space Academy. EMA also is doing quite a lot of trainings, and we would like to have a central point where different trainings could be made available for the different for the researchers. So maybe we can also have a little bit more in-depth discussion in the context of TEDAS, how best this can be organized. With regard to the capacity building, TEDAS is working on developing, let's say, benchmarking for what would be the main elements that could support the capacity building. The Commission is launching a project for capacity building for the primary use of health data from the Work Programme 2022 of the EU for Health. And we are aiming also to support the same approach for the secondary use of data, also building upon what TEDAS is doing, and especially supporting the twinning project, so that experts from the more developed countries can analyze the situation in the less developed countries and can provide assistance and support. But of course, one needs to have the benchmarking, which can also be built upon the experience of the member states and also the legislation. On the data literacy, that's a very important element. There are some measures which have been taken in the context of the regulated professions to strengthen the digital literacy of the nurses and doctors. Probably this can be done further on also with the support of the universities. And with regards to the lifelong learning for the doctors and nurses that have graduated, the European Social Fund program offers important resources. And I must admit that I do not have an overview of the current allocations under the operation programs. It would be quite interesting maybe to look into this, but there is also the possibility of 2025 midterm review of the cohesion policy funding, where additional funding could be dedicated under the European Regional Development Fund and European Social Fund for digitalization and for skills in the digital health.
Thanks, Joanna. I think we have almost reached the time that we had for the panel, but I have three short questions, one for Emmanuel, one for Peja, and then for Bernard. So I would like you to give me quick replies for this. Actually, I start with you, Peja, because it builds on to the capacity. So Finland has Findata, and are we ready now to implement the legislation, and will it be a walk in the park for us as we have been prepared?
Well, I would say that working at Findata has been walk in the park, like nice Parisian park, maybe more like an amusement park with pretty wild rides there. And I encourage everyone to expect that also in the other countries. But of course, we have a head start. It's obvious, and reading the EHDS proposal, it was very interesting because there are lots of familiar things there, and also interesting similarities, but also interesting differences. And it's very interesting to see that. But we are very warmly waiting for this network of colleagues in other countries to grow. We have been enjoying the cooperation with the French Health Data Hub, and when we are really looking forward to having other health data hubs in other countries, and of course we are willing to give our advice and tell about our experiences there. So really looking forward to that.
And that actually also builds to Emmanuel the question I want to ask you. So before the text will be accepted, you are one of the candidates. You're leading a consortium that is a candidate to do a pilot that leads into the final EHDS for the secondary use. So how does that help then in the implementation, and how does that help the member states?
Yeah, we are very glad to have succeeded in gathering this really wide consortium. And we are, of course, very proud to have Findata with us and Sanciano, but we also have Denmark, Norway, Germany, Croatia, Hungary, and I hope I don't miss any name. And we also have some research, European research into infrastructures like BBMRI or eBrains, and we also have Elixir. And so it's a very, very wide consortium with two main objectives. The first one is to build pipelines between all these national platforms, okay? So existing national platforms, in order to build a network so that we can implement this central service for having a metadata catalog. We can operate this central service for having a unique access form to all the countries. So all these barriers that we're talking about, we are going to, I mean, that's what we propose if we are selected. I think the selection, the official selection is in June or something like that. So I crossed my fingers, but so that's what we propose to operate these solutions to these barriers that we're talking about. And the second objective is to run use cases. So basically, to come back to the first question you were asking, to try to run some success stories at the European level. So we propose 9 different use cases. And if we are selected, then the Commission will select some of them out of these 9 stories to be run within 2 years, because the pilot is two years long, which is extremely short for success stories, but hopefully it will be possible.
Thanks. So final question to you, Bernard. You hear a lot of these kind of discussions on the European level in panels and different forums, and you have the industry background. So do you relate to this discussion from your industry perspectives? Are we talking about the real issues? Is this something that supports also the innovation in EU? And finally, is the industry taking enough into account and into these discussions when we are drafting the new ways of working in EU?
May I use a metaphor? It's when you build a house, you need to have a solid basement. That's the solid basement. Without the quality data, without that ability to know what type of data you have and the ability to have networks that works, it's very complicated to operate today in Europe. But you still have first floor, second floor. I mean, you still have other layers about standardization, about how the methodology, how you use the data, and what these data are made for. So I think we are extremely keen to see that phase moving fast, because I believe Europe is a little bit behind the US on that aspect, but has significant advantage because of the quality of the data once it's going to be in place. And I think the industry will be surging with many, many projects as soon as you will see the premise of what you're presenting here today.
Thanks. So that's the closing of our panel today. And one thing, if you didn't understand something, then you're not alone. There's a lot of citizens and communities that don't know that much about the secondary use of health data. So that's why the Finnish Innovation Fund actually made a short 1-minute video to explain what this is about. So I could show it to you now here. What is the European health data space and what does it mean for average citizen? So I hope we could have the technical working and we can see the video now. Then we could go into your questions. So please be prepared for asking the floor after we see that. Right, thanks. So let's go to questions. We have still 9 minutes to go. Don't leave yet if there's good questions for you. I have one question, which is, I know that the regulation also touches this topic in some level. So for countries that have health data in paper format, is it reliable to transfer them to computerized format, or should we abandon this data and start from scratch? I know that in the regulation it states that it's voluntary to move that data into the paper format. But how do you? Anybody wants to answer? Is it reliable to transfer it to the electronic format?
Well,
please.
I think that, for example, if we create templates and we have the right fields that can be filled online, it's better to move the data from paper-based to the template online in a standard structured format than to just disregard this data.
Emmanuel.
Papers, what it means, because it can mean a lot of things. If you're talking about what the doctors are writing on the paper, forget about it. Okay? There is an AI problem here of just reading. Even for human beings, sometimes it's very hard to read. So don't even count on the computer to read it. But okay, apart from joking, yes. I mean, I think it totally depends on the paper we're talking about. I guess that we could find some papers, some data on some papers which are extremely useful, which could be extremely useful and are very valuable. So we should not just throw them away, but we should not say, okay, all the paper data we should collect, and that would be totally insane.
Want to answer?
I think for many years we did perform clinical trials using paper to collect the information and move that then to database. I think the exercise is feasible. It takes time and money. And the validation of the data is a very important part to check the quality. So if you have time and money, I think it's feasible and can be useful in some specific cases.
All right, anyone here physically present would like to raise their hands to ask a question regarding the European collaboration or the new proposal? You have a very good chance to ask also Johanna regarding that. Johanna, please.
Thank you. Okay, thank you.
we were reading the proposal for EHDS, and I was quite surprised to find out that also the data from clinical trials is covered or included in the regulation. So especially for you, perhaps presenting the pharmaceutical industry, what are your reflections on that, and do you think it will be happening?
So the usefulness of including the clinical trial makes no doubt. The data are very clean, whereas the real world data are pretty messy. And they are extremely useful if you start to build models using, for instance, for measuring benefit and risk. Now, the protection of the invention is something that is very sensitive in the industry around data protection for the data. I believe that there is a movement towards more companies open to share the patient level data, because that's what we're talking about on the clinical trials. Not only the aggregated data as we do on clinicaltrial.gov, for instance. So I'm personally favorable, because I think this is an important step to accelerate the transformation, provided that the patent regulation is not, there's no risk of infringement of patent because of that legislation, but I think that's manageable.
All right. There's one question from the audience online. UK has seen a significant opposition to some health data sharing plans from public. With the increase of opt-outs, how does the EHDS plan to avoid this? And maybe Peja, you could also answer, because in Finland we have this opt-out system. So how do we avoid people opting out from the health data use in Finland?
Yeah, it's true that we have this opt-out principle in Finland, and we have been kind of surprised that there has been very little opting out in Finland, although we provide, of course, the kind of instructions how to do it very clearly on our webpage. And I guess that's also in English there, if you want to go and check how we instruct it. But yeah, but of course, I think that it all boils down to the informing the citizens, telling them your video was very nice, start for that, and telling about what's going on, and of course also telling about the because it's not a new thing that now we are starting to use their data. As we have discussed here, it has been gone on for decades already, but telling that, okay, we are still using your data, we are using it for good things, and we are kind of improving the data security and data protection. So it's actually, it's going to a better direction. So, but really like encourage discussion in the society.
Emmanuel, please.
The right way to put it is to say we want to avoid opt-out. I think we want to inform citizens as much as possible, and if we succeed, and I think that's the top priority in the list, information of the citizen, educating the citizen. And then after that, some citizens will say we want to opt out, but it will be a clear choice, and that's okay. And some citizens will say no. My belief is that most of the citizens will say it's okay with us, we don't want to opt out. But the goal should not be we are going to educate them so that will not opt out, because that will fail. So we have to educate without nothing behind this education process, saying, trying to avoid the opt-out. It's a very, very dangerous thing, saying we want to avoid opt-out. I don't like it at all, I'm sorry.
So we are not going to avoid it, just remove that from the recording. I think one thing that we found out from Tehdas Joint Action, actually quite similar what you said. We made a study of the citizens' perspectives regarding the health data, and we analyzed also scientific papers and so on. And we found out that the more the citizens know, the more they are favor in the health data use, and the less they know, the more they fear. It's almost like, with the immigrants and others, like the people who have less immigrants fear them the most. And it's same for almost every policy. And I think we just need to be open. We need to make clear communications with the health data, with the European health data space, and let citizens know the benefits. And as Emmanuel, as you said, if they want to opt out, then it shouldn't be a problem. We should make it easy, and that's an option of the citizen then. So that concludes the panel. I got to say the last word. So thank you all for watching, and thank you all for being here today. So the discussion continues in Twitter and other media, and happy to discuss further these ESTS topics. Thanks.